Hello everyone. Today we are going to talk about chelating agents. Chelating agents are the drugs which are used to treat heavy metal poisoning. These form ring-like structures with heavy metals. Usually, how do they act? They mainly act by forming a claw hold. Let us consider this as my chelating agent. My heavy metal reacts here and a claw hold is formed. This is called as claw hold. This whole complex exists in the form of a ring of 7 to 8 structures. Then this becomes a stable chelate. This stable chelate is usually excretable because it makes the heavy metal water soluble. With this background, let us see the characteristics of chelating metals. Most important characteristic of chelating agent is it must be water soluble so that excretion through kidney becomes easy. Second thing, the distribution of chelating agent must coincide with, should be similar to the heavy metal which has to be chelated, and most importantly it must have less or no affinity for calcium present in our body, because once calcium is present, once the chelating agent has higher affinity for calcium, instead of chelating the toxic heavy metal, it starts chelating our bodily calcium, resulting in hypocalcemia and tetany. These are the most important characteristics of a chelating agent. Let us go into chelating agents proper. Most important is British anti-Lewisite or Dimercaprol. Second one is your Penicillamine. Third one is calcium disodium editate. Then comes our Deferoxamine, Deferasirox and Deferoxamine. We'll discuss about each. Let us start with British anti-Lewisite. Obviously, the mechanism of action stands the same. It forms a chelate with the heavy metal. This British anti-Lewisite is usually used in the treatment of B stands for bismuth, A stands for arsenic, and BAL is also called as Dimercaprol. So, this is also used in the treatment of mercury poisoning. Most importantly, the Dimercaprol, these are the uses, is completely contraindicated in cadmium poisoning and iron poisoning, because the chelate which is formed under the influence of BAL is highly toxic. Okay, now let us talk about our second one, that is D-penicillamine. D-penicillamine is majorly used in the treatment of copper poisoning. Before talking about copper poisoning per se, we need to talk about Wilson's disease. Wilson's disease is, usually we have ceruloplasmin with us. It's a plasma protein, and ceruloplasmin chelates the copper which is present, excessive copper which is present in our body, and makes it easily excretable. In a patient suffering from Wilson's disease, this ceruloplasmin is on the lower end, resulting in copper poisoning. This copper gets accumulated in eyes, resulting in Kescher-Fleischer rings, or else in the liver, resulting in nodular liver. D-penicillamine is considered as treatment of choice in Wilson's disease. Wilson's disease is also called as hepatolenticular disease. This D-penicillamine in the case of Wilson's disease is given in the oral form and treatment is lifelong. The second most important indication of D-penicillamine is your obvious copper poisoning. This can also be used in many other diseases, but scleroderma is one such condition where D-penicillamine can be used, as well as in scleroderma, role of D-penicillamine is by increasing the soluble collagen. With respect to other indications, cystine stones of kidney are also treated by D-penicillamine. Now, let us talk about, we have finished BAL, we have finished D-penicillamine. Now, let us talk about calcium disodium edetate. With respect to calcium disodium edetate, there is nothing more to talk, but only thing is, it is a best treatment of choice for lead poisoning, be it acute or chronic. Before, calcium disodium edetate was available as sodium EDTA, but what happened was it chelated the body calcium, blood calcium, resulting in tetany. For this reason only, we started using calcium disodium EDTA now. And this calcium disodium EDTA is not used in the treatment of mercury. Why? Because the distribution is itself different. Now, let us talk about our last and one of the most important chelating agent, that is iron chelators. Deferoxamine and Deferoxamine. This is parenteral and this is oral. That's the major difference. And see, most importantly, iron chelators are used in case of thalassemia, where these thalassemia patients need to be given blood transfusions repeatedly, resulting in iron overload. This iron overload is managed using oral iron chelator, mostly Deferoxamine or Deferasirox, and is a lifelong therapy. Second thing, acute iron poisoning. In case of acute iron poisoning, usually we prefer parenteral Deferoxamine, as well as third one, this thalassemia patient also if not treated before, before going to the blood transfusion, if patient is not prescribed oral iron chelator, the patient ends up with transfusion siderosis. In this case also, we usually treat them with parenteral iron chelators. What are the parenteral iron chelators? Deferoxamine. Clear? Now, let us talk about all the adverse effects. Most important adverse effect, in fact, of all the chelating agents is infusion reactions. During the infusion, they are bound to cause some sort of chills, rigors, allergic reactions and all. Secondly, nausea, vomiting, diarrhea, hypersensitivity. Thirdly, see, in the mechanism, we saw that this ring is formed where a chelating agent is combined with a heavy metal, and this ring is stable. If at all there is no to maintain that stability, what we usually do is we give excessive chelating agent. If excessive chelating agent is not given, or due to any reason the amount of agent infused is not sufficient, there is always a chance of dissociation of the chelating agent and the heavy metal in the kidney. Chelating agent and the heavy metal in the kidney dissociates in the kidney, resulting in renal damage. So, to prevent this only, we always infuse more of a chelating agent. Let us say hypothetically a patient is suffering from 1 gram of copper poisoning, then we will make sure that we will give them 2 grams of Deferoxamine. This is what I am trying to tell. This stands same with all. In fact, this ratio of 1 is to 2 is best held with BAL, British anti-leviside. BAL is always given in a BAL to heavy metal ratio is always 2:1, so that the chelated ring, the ring which is formed at the end, is much more stable. With this, we will conclude our chelating agents, and thank you for listening.